teaching session of Department of Urology, Savai Mansingh Medical College. So today we have a discussion on step-by-step approach of transurethral resection of bladder tumor. So bladder tumor resection, as we all know, is very important because a complete and a good TURBT definitely affects the outcome of the patient. So today on this topic, we have Dr. Preetham, who is our second-year resident. He will present the approach to transurethral resection of bladder tumor, and it will be moderated by our faculty, Professor Nachiket Vyas. So today we have two special invitees with us. Dr. Kim Mamin, we know everybody, most of us know, he doesn't need introduction. He was Honorary Secretary and then President of North Zone Chapter of Urological Society of India. Previously, he was Professor, Head of the Department at CMC Ludhiana. And at present, he is Professor of Urology and renal transplantation at Himalayan Institute of Medical Sciences, Swami Ram Himalayan University, Dehradun. So welcome, sir, to our session. Thank you for coming and joining us. And next invitee today with us is Dr. Anshuman Agarwal. Again, a very senior urologist, and he's a senior consultant at Apollo Hospital, New Delhi, with a special interest in uro-oncology, robotic surgery. So welcome, Dr. Anshuman Agarwal. Thank you.
Thank you, sir. Thank you.
Thank you, sir. Thank you. So now I would ask Dr. Nachiket Vyas to moderate the session and invite the presenter. Dr. Nachiket, please.
Good evening, sir. Thank you for the introduction of our guest faculty today. And in continuation with our wonderful case discussion on CA bladder that we had, today we are going to have a short talk by our resident, Dr. Preetham Mandal. He is going to talk about the steps to a TURBT, and then we will have comments by our invited faculty, Kim Mamin sir and Dr. Anshuman. And I'd also like to add that today I have the pleasure of telling you that my father has also joined the teaching class and he wanted to join, so dad is here. And we can have him as our third invited faculty. So now I'm going to ask Preetham to share. Preetham, are you ready with your presentation?
Yes, sir.
Preetham, can you unmute yourself and can you share your screen?
Yes, sir.
Screen share kar lo.
Sound kam kar do. Okay.
Preetham, you have to share your screen.
Yes, sir. Is my screen visible, sir?
Yeah. Now it
Yes,
has
sir.
started. Yeah.
Can you make it a
And can you? Yeah.
Yes, sir.
Yes, sir. It's
Yes,
perfectly
Preetham.
visible.
May I start, sir?
Yes, please.
Respected teachers, seniors, and dear colleague, a very warm good evening to all of you. Today, I will be talking about step-by-step approach of TURBT. I would like to thank Dr. Nachiket Vyas sir for his kind support and guidance. NITS was the first to attempt removal of the bladder tumor by endoscopic route, and NITS, along with the Joseph Lister, an instrument maker from the Germany, were the first to develop a modern endoscope. In 1909, Beer was the first to destruct the bladder tumor by electrosurgical way. McCarthy and Alcock was the first to remove the tumor of bladder using a resectoscope. The indication of TURBT are mainly the diagnostic and therapeutic. It is done to provide the accurate information with regard to bladder tumor grade and stage. It is done to treat the superficial bladder tumor by removing whole the tumor along with the intravesical chemotherapy and immunotherapy. It also used to palliate the symptoms such as bleeding in invasive cancers where cystectomy or radiotherapy are not appropriate. In case if the patient is planned for radiotherapy for larger tumor, it is used to debulk the tumor. So before going to TURBT, the patient should be assessed and pre-operatively prepared. So a proper history should be taken. Physical examination, general physical examination, systemic, along with the colorectal examination should be done. Investigation for pre-anesthetic checkup like CBC, RFT, LFT, ECG, chest X-ray should be done, and radiological investigation like USG and CT urography is very important before TURBT for planning the procedure. And before TURBT, arrangement of blood is also important. And one day before TURBT, pre-operative orders such as part preparation and mean per oral mouth should be done. On the day of operation, in the operation theater, patient should be identified along with the procedure, what procedure he should undergo, and image and file should be displayed. All the OT materials like betadine, TRIVE catheter, antibiotics, 3-liter saline, it should be arranged. Endovision system and diathermy setting should be checked. Antibiotic prophylaxis should be given 1 hour before the procedure, and the irrigation system, normal saline or glycine should be placed appropriately. Which system is used, monotherapy, or according to which system is used, monopolar or bipolar receptoscope. The instruments that should be present in the table are metal dilators, OT urethrotom, cystoscope, receptoscope. Usually the old the loop should be older one, which was used for TURBT before, because the older loops are used in TURBT. Elix evacuator is used to remove the bladder chips, filter for the tumor chips. The bladder catheter, the TRIVE catheter 22 French, Eurobag and Fixocat should be present, and also asepto syringe. The type of anesthesia that is to be given is spinal or epidural, and general anesthesia in case of lateral wall tumor to abolish the obturator reflex along with the muscle relaxant. This is the chart. Urine cytology and upper tract imaging should be done before the procedure. Cystoscopy done to locate the tumor, its nature, number, and also the surface and bladder distensibility. TURBT or biopsy should be taken under the regional anesthesia or general anesthesia, and bimanual examination should be done before and after the procedure. The position is modified lithotomy position, which is supported by adjustable Lloyd Davis support. Bimanual examination under anesthesia should be done in every cases of the bladder tumor. In case of the tumor affecting the base of the bladder, the separability from the prostate and also from the rectal mucosa should be assessed. And the lateral wall tumors can be palpated by sideways movement of the finger. And in case of flat tumors on cystoscopy, if the flat tumors are present, the bimanual examination has an important role in assessing those kinds of tumor. Cystoscopy should be done. Diagnostic cystoscopy is very important in these cases. Examination of the internal meatus should be done with 120 degree telescope. Dynamic cystoscopy, here the bladder should be examined in different field conditions, one in full bladder and another in empty bladder. The bladder wall should be examined where the tumor is present, and also in empty condition, the opposite wall of the opposite to the tumor of the bladder. In case of bladder involving the in case of the tumor involving the bladder wall, the jet of the irrigating fluid can be used to internally palpate the bladder. If the bladder is involves the tumor wall, there is no indentation. But if the tumor does not involve the bladder wall, there is indentation with the irrigating fluid. Examination of the ureteric orifice should be done in cystoscopy. The determining of the size and base of the tumor examination of the diverticula is also important. If there is a small mouth diverticula, then incision of the diverticular mouth should be done to examine inside the diverticula, because 7% of the tumors are present in diverticula. Vaginal palpation or rectal palpation during the cystoscopy is important to take the deeper tissue biopsy. Bladder biopsy, there are two ways to take a bladder biopsy. One is a endoscopy forceps, that is cold biopsy forceps, and cold cup biopsy forceps, and another is a receptoscope biopsy. The disadvantages are subsequent hemorrhage may require further workup to with coagulation probe to stop the hemorrhage, and also the tissue fragments obtained by cold cup biopsy forceps are considerably smaller in size. A receptoscope biopsy is undertaken with the electrotome inserted in place of the diagnostic telescope. Random biopsy of any suspicious area are important part of complete evaluation. It is indicated in multiple tumors or with the positive cytology. The current consensus said the random biopsies are not indicated in low risk patients. The random biopsies are taken from the 4 quadrant as shown in the figure. Formal resection versus fulguration. Once
Hello, Pritam sir.
Pritam, we can't hear you. I think
that we've lost
signal problem. Perfectly
yes,
right.
yes.
So in the meantime, I would just ask Dr. Kim and Dr. Anshuman also. He said something about the 120-degree cystoscope being used as a routine procedure. So do you agree that you would do keep a 120-degree cystoscope always and do a cystoscopy with a 120-degree scope also every time?
I have a 120-degree telescope, but I very rarely use it. But 70 degrees, I always use it, because 70 degrees is extremely useful when you're doing a cystoscopy before doing a resection. But 120, I rarely use, very occasionally. Some of the indications where you can use a 120 is, especially when you want to see the bladder neck area or the prostatic urethra, then it may be useful. I don't do it regularly, but I've seen some senior urologists, especially in England, using a 120-degree telescope.
Okay, Dr. Anshuman, do you have any comment on that?
Yeah, so as Professor Maman said, I mean, 120 degrees rarely used. We definitely use a 70 degree for obese individuals. See, I can only say that most of the imaging can be done by 30-degree scope, keeping the bladder partially full and, giving a suprapubic compression.
Exactly.
So one can image around visualize around the neck. But in obese individuals, I think 70-degree assumes a great importance, where you just cannot, push the suprapubic region inside. So I think 70 degrees one should possess that kind of a telescope. But 120 I've never used, and I've not seen it being used.
All right. So I think most of the time, 99% we can do with the 30-degree only.
30 degrees.
With
yes.
the suprapubic compression and all that. But particularly when we have the Hopkins 2, which is the latest variety of telescope, which has a wide view. So almost 70 or 120 is very rarely used. Right. So thank you. I can, Pritam, you can continue your presentation, please. Yeah. Pritam?
Pritam, are you there?
I think again he's having some problem with the signal. Another thing that he said about the indentation with the irrigating fluid. Do you think, I have heard it for the first time. He said that if there is an infiltration of the bladder tumor, that particular wall will not bulge or will not indent with the irrigating fluid. So is it actually true? Dr. Kim and Dr. Anshuman?
So I have personally never experienced it.
Say it again, just say the question again.
He said in his presentation, Dr. Pritam, that if the bladder wall is infiltrated with the tumor, that particular part of the wall will not indent with the irrigating fluid. And
Your voice is
a
breaking.
normal bladder wall will indent. But I have never come across this kind of thing. For hearing it for the first time.
Your voice is breaking. I didn't.
Okay. We will. So anyway,
can you just repeat it again?
What I was saying, that in one of his slides, he said that if the bladder wall is infiltrated with tumor, the irrigating fluid will not indent the bladder wall. If it is normal, it will indent the bladder wall. Is it true? Because I am hearing for the first time, and you might have also heard it for the first time. So that's right. Anyway, Preetham, are you there?
Yes, sir. Yes, sir.
So go ahead, please.
The techniques of bladder tumor resection are as shown in the figure. Horizontal approach. In case of spherical tumor, we resect the tumor in the horizontal direction. For the extensive large tumor, vertical approach is applied. And for the small tumors with a small stalk, dividing the stalk is used. Laser coagulation allows a minimal invasive ablation of a small papillary tumors up to 2.5 centimeter, and ND-YAG laser has the best properties. The most significant complication is injury to the bowel. Laser therapy can be more expensive than a resection because of the cost of laser fibers. There is a negligible bleeding, and also there is no risk of obturator reflex. Nowadays, in-block resections are done by thulium laser fibers in many centers. For the mosaic patches, flat pink patches without obvious exfoliative tumor, these patches should be biopsied and then coagulated with the Rolly ball electrode. For extensive area of these superficial tumors, the process can be speeded up by using cutting current. En-bloc resection is performed with the traditional loop electrode, hybrid knife, holmium laser, thulium laser, or KTP laser, and also can be used with the Collins knife or the loop electrode. It involves the excision of the entire tumor with underlying segment of the muscle, with the specimen being resected and extracted intact rather than piecemeal. The benefits are less cautery artifact and thereby allowing more accurate assessment of muscle invasion by the pathologist. This is the picture showing the en-bloc resection of the tumor. First, the mucosa is lifted by injecting the normal saline. Then the incision line is marked with Collins knife or laser fiber. Then the tumor is resected in block with part of the muscle. Here, this picture shows the tumor before the resection, and this picture shows the resection site after the en-bloc resection of the tumor. It is most feasible in papillary tumors with a distinct stalk, and the specimen extraction may be difficult in large tumors. In those cases, the specimens should be fragmented into pieces to allow extraction through the receptoscope. The potential disadvantage of en-bloc resection is possible disruption of tissue at incision line, and also there is a risk of excessive tissue penetration there. In case of large papillary tumors, more than 4 to 6 centimeter diameter, the first difficulty is with the conventional irrigating system. The tumor seems to move away from the telescope as the bladder fills up. So as soon as you start resecting the tumor, the bleeding makes vision even worse. So this difficulty is overcome by using a continuous flow receptoscope. If the inflow and outflow are correctly adjusted, the tumor stay at the place and you can resect the tumor according to your plan. The first aim to expose the stalk by resecting the overhanging bush, that is the villi of the tumor, and then overlying the bush is resected to reveal the stalk. The stalk, once resected, the main feeding vessel should be coagulated with the Rolly ball to achieve a less bleeding when resecting the tumor. Then trimming the remaining tumor from the edge of the stalk. After removing all the tumors, the biopsy or separate biopsy should be taken from the resected tumor base to send separately. The tissue from the bush and the stalk should be sent in a separate specimen. ports to the laboratory, leveling as a push and the stop. With the rolling ball electrode, the tumor base should be coagulated. After a resection is complete, empty the bladder and careful bimanual examination should be done. And once hemostasis is achieved, continuous irrigation should be started. This is the method of hemostasis. The hemostasis should be achieved with loop electrode, and this picture shows the bladder, the tumor base after removing the tumor. The margin of the tumor base should be coagulated with the loop electrode. This is called as a Hemming's technique of hemostasis. A very large papillary tumor, there are two ways of resecting the very large papillary tumors. One way to resect as many as tumor that you can see, as long as you are able to maintain the clear field of view, and then come back another day to finish the job rather than risking perforating the bladder. And another way is the Helmstein technique, in which the bladder is filled with the balloon inflated with the glycine and kept for 6 hours. After 6 hours, the balloon is deflated and the trivac catheter is inserted and irrigation is started. The tumor is sloughed out, the villi of the tumor is sloughed out, and the remaining stalks of the tumor is as shown in the figure. So the remaining stalk can be removed in the usual way. This technique can also be used in case of bleeding from the tumor base. In case of invasive solid tumors, the purpose of TURBT is to provide accurate grading and local staging information. And it is not necessary to remove all the tumors if the patient is planned for cystectomy. For the patient for whom the radiotherapy is planned, TURBT controls bleeding and provides the symptomatic relief from the frequency and stangury. And it also debulks the intravesical tumor, leaving the less to be destroyed by radiation. In case of anterior wall and the dome of anterior wall tumor and the tumor in the dome, the decompression of the bladder combined with suprapubic pressure can be used to reach up to reach of the loop with the resectoscope. In inclining the tables of the patient is in the head down position may make the resection a little easier. If these tricks fails, then a long resectoscope is used to remove the tumor. For the tumors in diverticula, it is safe to use a cold cup biopsy because the diverticula there is no muscle present, so the bladder wall is thin. Perforation may be a possibility. So these tumors best is to use the cold cup biopsy and then rolling ball diathermy for coagulation. In case of lateral wall tumors, there is a risk of obturator reflex and inadvertent perforation of the bladder. To lessen this risk, there are few techniques which are recommended, like minimizing the distension of the bladder to minimum need to perform the section. Bipolar cautery may eliminate the reflex. If the patient is general anesthesia, muscle relaxation can be administered to abolish the reflux. And the best way is to do a obturator nerve block. Resetting the tumors in the region of ureteric orifice, use of pure current will reduces the likelihood of scar occurring, and resection stroke should be as quick as possible to minimize the possibility of cauterizing the ureteral orifice closed. Alternatively, guide wire should be placed and so that a DJ stent can subsequently be placed easily. If the patient have a tumor in ureteric orifice and it is resected, follow-ups with IBU should be done to determine whether the ureteric orifice is obstructed or not. The resecting tumors close to the internal meatus. As you can see in this picture, there is a tumor involving the internal meatus. These tumors should be removed along with the part of the prostate for proper radicality. The repeat transurethral resection of the bladder should be done in case of The complete tumor removal is not always possible if the tumor is excess in size or volume, anatomical inaccessibility, or medical instability requiring a premature cessation of initial resection or risk of perforation. Second, TUR is necessary within 6 weeks in case of incomplete resection with these. And if no muscle is present in the initial specimen or high-grade T1 tumors present in the initial pathology, initial tumor biopsy, or high-risk, high-grade TA tumors. This is the chart showing adjuvant chemotherapy for superficial tumors. In case of low-risk tumors, installation of intracycle chemotherapy, that is mitomycin after TURBT, should be done. And there is no documentation of, there is no guideline to give BCG in these kinds of tumors after installation of BCG, after installation of mitomycin C. In case of intermediate risk tumors, after giving mitomycin C, the BCG should be given after 4 to 6 weeks, 6 cycles, then 3 weekly for 3 months, 6 months, and the 12 months. For the high risk tumors, after giving mitomycin C, these BCG should be administered up to 3 years. The complications that can happen in case of transurethral resection of bladder are the most common complication of minor bleeding, which can be treated by continuous irrigation. Irritative symptoms can be treated by the medication, and the major complications are uncontrolled hematuria and clinical bladder perforation. Perforation tends to occur in elderly patients with the large posterior wall tumors and previous treatment with the multiple courses of etoposarcoma therapy. The incidence of perforation can be reduced by attention to the technical details, avoiding the over distension of the bladder, and also abolishing the obturator reflux. If perforation happens, then on-table cystography should be done to look for whether perforation is extraperitoneal or intraperitoneal and the severity of perforation. In case of extraperitoneal perforation, it is managed with the prolonged urethral catheter drainage. Intraperitoneal perforation is less likely to close spontaneously, so requires a laparoscopic or open approach. TUR syndrome from the fluid absorption is very less common. This is a guideline suggesting the surveillance strategy for the low-grade tumors after initial resection. After 3 months of the initial resection, cystoscopy should be done, and then yearly for 5 years. And the upper tract imaging is not necessary if hematuria is not present. For intermediate tumors, every 3 monthly for 1 year, 6 monthly for 2 years, and then after annually for rest of the life. And imaging should be considered 1 to 2 year interval, especially for the patient with hematuria. In high risk patients, every 3 monthly for 2 years, semi-annually 6 monthly for 2 years, then annually for the rest of the life, and imaging annually for 2 years, then consider lengthening. This is a video showing the en bloc resection. Initially, cystoscopy should be done. Cystoscopy is done to look for the ureteric orifice, the size of the tumor, location of the tumor, and the tumor base. Here, the police knife is used to mark the initial incision line inferiorly to the tumors. The incision line is being deepened to include the bladder wall muscle. The specimen is being extracted in toto. Hemostasis is achieved by coagulating the tumor bed and the margin of the tumor bed. After the resection, the tumor tissue is sent for the histopathology, and the intravesical mitomycin C is given to the patient. With this, I would like to conclude my presentation. Thank you.
Thank you. Before Nachiket takes over, I would again, because in the initial phase I was muted. So Dr. A.L. Vyas, I will welcome Dr. Anandilal Vyas, a very senior urologist and definitely almost somebody who is from our own family. So welcome, sir. And I would request you to join us for your comments also. And there are a few other senior members like Dr. Bhatyal. Thank you for joining us. And there are 2 or 3 more senior members. All of you are welcome and you can give your comments. So Nachiket, please go ahead.
So thank you so much. Sir, we were asking about one question, that why Preetham said that inside the cases of a large bladder tumor, the irrigation fluid will not be able to indent the bladder. I think that
Hello,
why he
Hello.
there's some problem inside the voice. I think
Yes,
today.
sir. आपका वॉइस रिवर्ब हो रहा है. आपके पापा का स्पीकर म्यूट कर दीजिए.
Okay, so I hope that I'm not.
It's still echoing. Still echoing. Nachiket, the voice is echoing.
Okay, sir. So now am I okay?
Yes, sir. Now clear.
Better.
So what he meant was that, sir, when we were going through the literature and preparing his seminar, then inside the cases of malignant tumors which are invading the bladder wall, previously when we did not have ultrasound, then they used to do a cystography, and in cystography the bladder which used to be muscle invasive would not distend. So we would have an irregular cystography. If there was a superficial bladder tumor, it would take its normal shape. So I think that he couldn't explain what he was wanting to say. It's a very crude thing, but what he meant was that if it's a malignant bladder tumor, then the distensibility of the bladder would be reduced. The bladder would be irregularly, distended, and sometimes there might not be any distensibility of that side of the bladder if the tumor is fixed. So this is what I think that he meant, and so he wasn't able to explain it properly. I'd like to again share with the people who have joined us and with faculty who have joined us that this was en bloc resection video which was done in our department, and Shivam sir was kind enough to give his video. And now I think that we'd like to take the comments of our special invitees, maybe Kim sir and then Anshuman sir, and they can give their comments about what they think that how he presented, and if there were any lacuna in the presentation. Kim sir, can you come in for your comments, please?
Please unmute yourself, Dr. Kim. Dr. Kim, can you unmute yourself, or you are not able to? Okay, I will request the technical staff.
Yes, he's unmuted.
Dr. Anshuman and Dr. Kim.
Yeah,
and
I just
Dr.
wanted
Vyas.
to add.
Yes, sir.
Yeah. Can I speak?
Yes,
Yes,
sir.
sir, please.
You are unmuted.
Yeah,
please.
I just wanted to add 1 or 2 points. First is nowadays many of the TURBTs which many of us do, we either do it with imaging like ultrasound or a CT or an IVU. And I think I just would like to share the merits and demerits of these 3 common imaging techniques. But I think ultrasound is very, we can miss out on a lot of upper tract tumors if we just do an ultrasound alone. I think while I was being trained, the most popular imaging was an intravenous urogram. I'm sure ALVR sir also would agree with me. And later on, we all have converted to CCT or a CT urography. And because we will never miss out any small upper tract tumors, which is staring at us and which we would have otherwise missed. So that is one thing which I wanted to mention. Second is, if it is a lateral wall tumor, I always ask my anesthetist to give a general anesthesia to avoid jerks, because jerks are quite dangerous. You can perforate the bladder. But so better option would be to give general anesthesia if the patient is having a tumor in the lateral wall. And second thing is, another thing which I find useful is to do a roller ball diathermy, especially when you're doing an en bloc resection and you want to diathermize the base of the tumor. And next point which I would like to emphasize is that always put the tumor in two pots. The main tumor, and second is in one pot, and second is the base of the resected tumor in a separate pot, because it is very important that second pot is the most important thing. That should have muscle in it, and the pathologist should comment whether that muscle that we have resected is infiltrated by tumor. Only if the pathologist is able to comment that the muscle is infiltrated by tumor, can say this is a muscle invasive tumor. Number one. Number two, in large tumors, like Preetham was telling, large tumors, what I do is, and what I have learned from some of my seniors is that when we know that it's a large tumor, we request the anesthetist to give an epidural cannula. And you can resect it in two sittings. One sitting, resect half of the tumor, take the patient back after a day or two, use the same epidural cannula, and you can complete the resection in the second sitting. And I have done it in 3 sittings also. But epidural cannula is a very useful armamentarium and option where you can use it, and you can give top-up doses on the second day or the third day. So that is one thing to respect. Because you base of the tumor, number one, for 2 reasons. Number one, if you know that it is an invasive tumor or muscle invasive tumor or a superficial tumor. Second is, if it is a muscle invasive tumor, we would like to give the patient neoadjuvant chemotherapy, 4 cycles. Now, our medical oncologists always insist that it should be a complete resection for 2 reasons. They would like to give neoadjuvant chemotherapy, which will be more effective if the resection is complete. But if it is a maximal resection or if there is residual tumor, then the NACT is not as effective as they would like to have it. So that is one thing. So complete resection should be our aim and option. So that is one thing why we should always do a complete resection. And some of the things that will help us do a complete resection is, one is use epidural anesthesia with epidural cannula, and do a complete resection in 1 sitting or 2 sittings. Yes, I think that's it.
Another question that I would like to ask you is that inside the exams, we see many of our residents floundering about the bimanual examination. What exactly are you doing inside a bimanual examination, and what do you see, and how important is it, and how do you interpret your bimanual examination? How would you interpret your bimanual examination?
It has been years since I did a bimanual examination. Nowadays, many of my teachers and colleagues, they don't do a bimanual exam. Number one, those intervals used to capture from bimanual exam, we are able to capture it either through a pre-op contrast CT or doing a cystoscopy. So I have not done a bimanual examination for at least 1 or 2 years. I don't know. I would like to get opinion from
no, perfect, sir. And I think that
Yasser.
I think that is absolutely correct, and it's high time that as examiners also we stop asking this exam inside this question in our exams. This because all the boys interpret a bimanual examination separately in the presence of a good biopsy. How important is it? I also am very skeptical about the interpretation before resection and after resection of a bimanual examination. Now I'm coming to my next invited faculty, Dr. Anshuman sir. How commonly are you using NVI narrowband imaging inside your resections, even though we do have narrowband imagings inside our resections over here inside our camera mode also? And what is the present status of en-bloc resection? 2 questions for you. And what are the indications of en-bloc resection, and what are the contraindications of en-bloc resection? This is because I've seen you demonstrate en-bloc resections a few times inside conferences. So your thoughts on that?
So, Nachiket, so let's talk about narrowband imaging. So I personally do not have the equipment currently for narrowband imaging. I'm not aware if the regular cameras are providing that kind of gadgetry. So I'm not aware of that. But narrowband imaging we are not using. And so far, TURBT is a reasonably common surgery, and cancer bladder is a reasonably common cancer that we treat. So I don't think that we have suffered on account of narrowband imaging. Number one. Number two, so regarding en-bloc tumors, so I had prepared some points that I wanted to make. The Puneet gave a very good, Preetham made a very good presentation. So there were some points which I would like to dwell upon that also. But first, coming to the en-bloc resection. So en-bloc resection is only used for pedunculated tumors. I would say the tumor is preferably less than 2 centimeters in size, because then the whole purpose of doing en-bloc resection is defeated if you have to chop the tumor to get it out. So the whole purpose of en-bloc resection gets defeated. Contrary to the popular belief that you will get the muscle in the en-bloc, I have never seen the muscle come in the en-bloc, or maybe the pathologist has not made the effort to look for the muscle in the en-bloc resection.
That's
the
a very
biggest
important
advantage
point.
of en-bloc resection, which I feel, is very recently there was a case where I was unable to pass a perfectly normal urethra, but I was unable to pass a 24 French resectoscope inside. So what I did, the patient had multiple pedunculated tumors, all about 1 to 1.5 centimeter size. So I took a Bugbee electrode. I did not have the laser that day. So I took the Bugbee electrode and I used a 20 French cystoscope. And through that, I did en-bloc resection of all those tumors, and then took cold cup biopsies from the base and used the same Bugbee to fulgurate and have a nice, and today I have received the biopsy, which is low grade, laminas free, but then muscle is also involved. Whereas previously, when I thought that en-bloc tumor gave me the muscle also, then I was surprised to see that the pathologist saying that no muscle found in the specimen. Although I was lucky that it was a low grade tumor and only not even the lamina was invaded. So we were confident in telling the patient that, man, it does not matter. But one must always be very conscious about the fact that when we are doing en-bloc resection, so saline does a lot of job. So the flowing saline, it lifts the tumor, and the tumor mucosa is lifted and the muscle is pushed behind. And if you are thinking that you have taken the muscle in the en-bloc, so you are highly mistaken. That is not going to happen, and you have to take it as separate chunks. And in a small base tumor, it is preferable to take cold cup biopsy than to take it with a loop, because then you will burn the entire specimen. It will be a small. So I think en-bloc tumors is only for smaller tumors, pedunculated tumors, not wide base tumors. So and tumors which are not larger than 2 centimeter, which you can just extract out of your continuous flow resectoscope. I think Dr. Shivam wants to make a point.
Yeah, I just want to make exactly what there are 2 methods of doing an en-bloc resection. One is injecting normal saline at the base of the bladder tumor and then doing en-bloc resection, and other is without injecting normal saline. If you inject a normal saline just under the mucosa, there is as you said, that the muscle goes down and you just lift up the mucosa, and you would not get the muscle in the biopsy. But if you're not injecting normal saline, we did the same thing and had the same results. Now we do not inject normal saline at all. We make a deep kind of incision around the tumor, which goes up to the muscle, and then we lift up the whole bladder tumor. In that, we have every time we have got the muscle. So it is important that you don't inject normal saline just below the mucosa, which will definitely lift up the bladder tumor above the muscle. So I think that is making the difference. So if you do not inject normal saline and you go deep to the muscle and then resect, you will get the muscle.
Yeah, so we are not injecting a normal saline anymore. And lately, I mean, maybe first or second case, I must have injected it. Then after that, we have not done. But even then, the saline flow that you are using, that also kind of goes in between, and it tends to separate the mucosa and the muscle. And sometimes you might get fooled. So I think deeper biopsies separately is something that you must take to avoid an embarrassment, once the biopsy report comes that no muscle seen. So just I would make very quickly, I will make in 1 minute, I'll make a couple of points. So regarding the imaging of TURBT patient, so according to guidelines, for a solitary small tumor which looks low grade, CT scan is not indicated, but I think it is always safer to do a CT scan, as one may be having multifocal tumors which are a seedling from upper tract. So upper tract imaging is best done by CT scan. But on the contrary, small tumors, I have seen many times the CT scan will not pick up in the bladder, because during the CT scan, the contrast distends the bladder. It is high dense contrast, and sometimes if you have missed that point of imaging where you can see the enhancing tumor and the filling defect in the contrast, then many times I've seen CT scans, they report that there's no tumor seen inside the bladder, and then the patient is confused. So then we show them pictures of the ultrasound. So ultrasound is something, a very good modality for imaging the bladder tumor. Even the residents can do imaging of the bladder tumor. Regarding anesthesia, the preferred mode of anesthesia, since the time I've been in corporate hospitals for last maybe 13, 14 years, I've always used general anesthesia, and I've always been very, very happy with general anesthesia. Doing it under spinal or epidural gives me a heart attack, because anytime the jug will come and you will end up in a perforated bladder. Obturator nerve block is more of a mental, this thing, because everybody will have different capabilities of giving the obturator nerve block, and you may be very good at giving it, or you may be not good at giving it. So that is something, that chance that you cannot take. Now, if you don't, even with the bipolar, I have seen that the obturator jug comes. So that key is that you keep the bladder partially distended. Don't distend it too much. Keep it emptying, because many times happens in TURBT that the small chips of the bladder tumor, the fluffy kind of material, it will block the outflow of the continuous flow resectoscope, because the outflow of the continuous flow resectoscope has got minute holes. So these holes will get blocked by these tumor bits, and the outflow reduces, and suddenly you will find that the bladder is grossly distended. So that is the time when you can perforate it. That is the time when you are more likely to land up with an obturator jug. So even in my peripheral practice, when I used to go to one place to operate, the anesthetist will always be very keen to give spinal anesthesia. So when closing on a lateral wall tumor, what I will ask them to give us short injection of S-choline, intubate give a laryngeal mask, and that is very comfortable. In 10 minutes time, the choline action will go off, and you can resect the lateral wall tumor. If you are working in a periphery where the anesthesia fellow is insisting on kind of doing it under spinal or epidural. So large tumor, one must always have a stepwise approach. Don't mess up inside the bladder, that resect from all corners and start bleeding. Have a stepwise approach. Do one tumor, do second tumor, do third tumor. And if you are happy with the hemostasis, just stage the procedure. Come again after 2-3 days. Let those areas heal partially, and then remove the other. And once in my lifetime, I've also had to do a perineal urethrostomy to resect the bladder tumor. So a perineal urethrostomy, because I couldn't reach, the bladder tumor was on the dome of the bladder. I couldn't reach obese individual. So once in my lifetime, out of maybe hundreds of bladder tumor resections, I've had to do a perineal urethrostomy. And one should achieve maximal resection of the tumor, because another important point is that at the end of the day, when you offer cystectomy to a bladder cancer patient, he may refuse. So if you have done a maximal tumor resection in cases of pedunculated tumors, if you have done a maximal tumor resection, then the radiotherapy works very well on the bladder. So one must try to achieve a maximal tumor resection, so that chemotherapy, radiotherapy, all these modalities, they work better. Thank you.
We had a comment from Neeraj also, sir. And I think that I'll just invite. Yeah, I think I'll just invite Neeraj also, because Neeraj said that inside his specimens, muscle is present in 90% of the time. So Neeraj, are you with us, Neeraj, still?
Neeraj sir, please unmute yourself, sir.
And, in the meantime, if Dr. Vyas has to make any comment, please, you are most welcome, sir.
Sir, I think that he has just left Abhi right now. Somebody has come to meet him, so he's just left. Yeah.
Okay. So in the meantime, Dr. Neeraj comes, I will just make a comment about the maximal resection. Even if the patient is not going for radiotherapy, I think maximal total resection of the bladder tumor should be done. Because even when after the pathology, after the cystectomy comes T0, then the prognosis of the patient is definitely better. After a complete resection, and in pathology, you find that it is T0 lesion. So this has been seen in many studies. So I think if possible, we should do a complete resection, even if we are going for a cystectomy. And second, Neeraj, are you there?
Neeraj, have you joined, Neeraj?
Yes, sir. Neeraj sir is here.
Okay. Just try to unmute him.
Neeraj sir, please unmute yourself. I send you a request.
In the meantime, we have Dr. Bhatyal. Please unmute Dr. Bhatyal also. And if he has any comment to make, he will. I will ask you about Dr. Kim and Dr. Anshuman about the imaging study. Nowadays, we are having MRI also. And there are a lot of studies in our center also. We have done a study on VIRAD scoring. And VIRAD scoring is becoming popular as PIRAD scoring in CA prostate. So what do you think about the VIRAD scoring in bladder tumor? Dr. Kim and then Dr. Anshuman, please.
I think MRI is getting more popular. I would say that the information that we can capture, especially in a muscle invasive tumor from MRI, is a lot better than what we capture from CT. And VIRAD scoring is useful, especially in the context of invasive tumor. Yes, I think VIRAD scoring is getting important more and more in the next coming years.
Dr. Anshuman, anything? Any comment?
Yes.
Anshuman, sir, you have to unmute yourself, please.
Unmute yourself.
Sir, please unmute yourself.
Yeah. So MR is a very sensitive imaging for assessing the depth of invasion into the bladder. So it is not very popularly used in my place, and we are not routinely using, other than when we do a PET MR or staging the muscle invasive bladder cancer. But I am sure that MR is a very, very important tool to assess the depth of invasion. But the final diagnosis has to rest on the histopathology. So many times the patients are shying away from doing a very costly investigation, because the final word is the histopathology, unless it is an obviously invasive tumor and with very vesicle spread. But I think it will come up in a bigger way once the MR costs are reduced and all those things are.
I have Dr. a comment to make.
Yes, Nachiket, go ahead.
Some the comment that I want to make about CT and MRI is that I don't think that there is any much of a difference inside those large tumors which have got perivesical extension, which are locally advanced tumors, or even those tumors which are large. The problem comes when we are dealing with very small tumors, papillary tumors which are less than a centimeter, subcentric tumors, or which are flat. Sometimes if the bladder is over distended, then also they get flattened out. If the bladder is under distended, they get, we cannot see them inside the cuts of a CT or an MRI. And we all know that CIS, any modality will not be able to pick up CIS. So as far as those large tumors which are broad-based, I don't think that there is a difference between CT and MR. Once we have better modalities to pick up these small tumors, these sessile, small, subcentric, then I think that they'll start making a difference, whether we have to in the future with the advancement these CT and MRI, they're going to make a difference there. So this is the point that I wanted to make, sir.
But
Yal sir is with us.
Yeah, no, everything has been covered up very well. I have only one comment to say, as I think Anshuman said about this obturator block. I think we should forget about that. It's hardly ever it has been successful. In fact, it's just wasting of time. All of the modalities has been discussed, and those things can be practiced to prevent the obturator jerk, and one has to be very careful. The rest, everything I think has been covered up very well. I must congratulate everyone in this regard.
Thank you, Dr. Bhatyal. Only thing is about the obturator block, the blind obturator block may not be very useful, but nowadays we have nerve locators with ultrasound guidance. We can put obturator block, and many of them have very good results, almost very good sensitivity, 90 to 100%. So in good hands with good experts, I think they can put obturator blocks which are working. Anyway, most of us are not conversant with obturator blocks, so probably it's not useful for us. Yes, Neeraj, if you have joined, just comment on your end block resections.
I think that Neeraj is not here, sir.
Okay, fine.
Yes,
so
sir.
let's
Sorry,
go ahead.
sorry, sir. I just, hello.
Yes,
Neeraj,
Neeraj.
go ahead.
So, Neeraj, you were making a comment about your en bloc resections, in which you had stated that you get muscle inside 90% of your cases. So, if you can just share your experience, what your experience has been and how often. This is because Anshuman sir was saying that he many times does not get muscle, and also what has been your observation regarding en bloc resections, Neeraj?
I think we have been doing en bloc resections in our department. The cutoff limit for bladder tumors, as far as the size is concerned, is slightly higher than what was, I think mentioned for about 2 centimeters. We generally do en bloc resections up to 3 or 4 centimeters. In fact, we had done a small study also of about 25 cases recently, and it has been sent for publication. And where we found that the yield of muscle in those en bloc resections was more than 90%. I think it was, if I'm right, it was 93 or 94%. Only in one patient we didn't get a muscle in the biopsy specimen. Otherwise, we had biopsy in all the specimens. So that is one of the, I believe, the biggest advantage of doing an en bloc resection, that you get a good biopsy in one specimen. As far as the technique of en bloc is concerned, sir, I have a slightly different technique than what Shivam sir used. I think he used a Collins knife. I prefer to use a loop. And the loop is slightly straightened out. It's not a classical TUR loop, but it has been straightened out to an angle of about 150 or 160 degrees. And then just by just gentle nudging with the end of the loop, we do an en bloc resection. So overall, I think it's a wonderful technique for small bladder tumors, and we generally do it till 3 or 4 centimeters. That has been my experience, sir.
I think that technique was the classical technique, which was first described by SGPJ many years ago, in which they made the loop obtuse. And this is how Dr. Anish Srivastav, he first did en bloc resections and reported them in Indian Journal of Urology. Thank you, Neeraj, for your comments. Now I'd hand over the proceedings to Shivam sir for maybe finalizing today's teaching program.
If any faculty has any other comment to make, please, they are most welcome. There are few things that we can discuss. One is about the complications of TURBT, about the bleeding, post-operative bleeding. There was one study I remember when sometimes you do not exactly pinpoint the bleeder, and then they did a carbon dioxide cystoscopy. Instead of doing a normal saline cystoscopy or a glycine. So in that carbon dioxide cystoscopy, they were able to identify the bleeder and cauterize it. We have also tried doing a carbon dioxide cystoscopy, though not for a bladder tumor resection, but just a simple cystoscopy. And we have been, have found out that it can be a useful tool. in some of these cases. Any comments from any of the faculty, Dr. Anshuman, Kim, and any other, if they have any experience about carbon dioxide cystoscopy?
No, personally, I don't have any experience with carbon dioxide cystoscopy. So I think we will definitely give it a try if it is, if you say that it has some merit, so we can definitely give it a try. But then the thing is, how much pressure should one use? How much filling in the, from where to regulate that? Because when we are doing a laparoscopy, we have got an insufflator to regulate the abdominal pressure. But with, a cystoscope, so I'm not sure how we will regulate the pressures inside.
Exactly, you just with the insufflator only, you have to just put it to the cystoscope. That's all. I think.
Well, I remember
Shivam,
that. Sir, please.
Yes,
sir,
yes,
sir, please. Yes, sir.
Yes.
Sure.
Yes, Dr. Kim.
I have no experience with carbon dioxide cystoscopy. I don't have any experience with carbon dioxide cystoscopy. Yeah, that's all I have to say.
Right.
Well,
So
I remember that carbon dioxide cystoscopy was done in a few patients, and that started by default. Actually, Shivam sir, I remember I've been working with him for many years now. He was doing some lab procedure and he wanted to do some cystoscopy in some patient, and he was getting very restless. The water wasn't coming from the other OT, glycine wasn't coming, so he just took the carbon dioxide insufflator that we use in laparoscopy and put it in a cystoscope. I remember it was absolutely beautiful. The whole of the bladder, the vascularity, it was even better than what we were seeing in a normal cystoscopy when we're using saline or glycine. So yes, I mean, it can be done, and we've seen it. It started by default. I think one thing that he didn't tell that it was on account of his impatience that we did a carbon dioxide cystoscopy. So yes, हमको और regularly करना चाहिए, sir. We should do it more regular.
Right. I think so. So it needs a little bit of standardization. Sometimes these bubbles maybe are very difficult sometimes. So I think this may be standardized and we may improve upon it. Another thing that Dr. Kim had said about the bimanual examination, it never does a bimanual examination, but the guidelines still do have that bimanual exam, even the European guidelines, EU guidelines. Though we also do not do a bimanual examination. So any comment from the faculty, Dr. Anshuman and other people, are they doing bimanual examination routinely in TURBT?
No, not at all. Not at all. We're not doing it routinely.
So why they still, guidelines still say, I don't know why.
I don't know. Maybe somebody has forgotten to remove it from it. It's just copy and paste is going on.
Right. I think
that even this should be stopped.
At least in examinations, it should be.
Yes, surely, sir.
Right.
Surely.
Right. Another thing that Dr. Preetham also said in his presentation was any tumor which is near the ureteric orifice, we resect it completely. Yes, you should not use cautery a lot there. Do you do a routinely IVP post-operatively in these patients? As he said, we do not do routinely an IVP. Most of the times the patient is having some pain or on ultrasound there is dilatation, then we would think of doing a imaging study, otherwise not. Any comment from the speakers, faculty?
Quite true. I think even while doing a check cystoscopy, you can have a look at the orifice. So recently, I remember I did a check cystoscopy. In fact, the patient had a muscle invasive bladder cancer. We resected the orifice. We did a PCN for him. We counseled him for cystectomy. He did not opt for it. So now he came back with CT-RT done and with a PCN in situ. So we wanted to put in a stent, but I found that the orifice had stenosis. So we had to incise the orifice and then put in the stent. So I think cystoscopy gives you a good opportunity to look at the orifice. And if during the follow-up, the patient does not complain of flank pain, and you can once do an ultrasound and see if there's no dilation of the tract, then probably contrast imaging can be avoided.
I have a question.
Right,
Anshuman, you said, suppose there are multiple tumors, they're looking low grade, they're very close to the ureteric orifice. The patient is my elder brother. Let's be very clear about that. And I resected all those tumors and I had to put in a DJ stent. Now the question of BCG. Okay. Now, once the BCG starts, should I carry on with the complete induction with the DJ stent inside, or should I take out the DJ stent maybe after 2-3 installations?
So I think you must keep the DJ stents during the BCG, because once you have kept in a DJ stent, then it is rest. I mean, you can presume that you have led to reflux of cancer cells into the upper tract. So I mean, if the BCG also goes into the upper tract, there is no problem with that. I mean, how would
no, I kept the
I think
BCG only for the.
one should keep the stent
I
for
kept the BCG. I kept the DJ stent only for that reason, that the lower ureter, I did not do the ureteroscopy because I felt as if there is no tumor coming out of it, but there were small tumors on the complete, ureteric meatus completely. So the DJ stent will do the job. But one thing I had to practice was whenever I will pass the BCG, I'll keep the feeding tube inside. I will not let the patient void, because then it will reflect right up to the kidney. There are cases in which there are certain problems. I don't want to enumerate all those things. So I'll keep the feeding tube in, and then after he has to turn over and all those things, I will empty the bladder and take out the feeding tube, so that kind of reflux is not there.
In fact, BCG with DJ stents is being used for
upper tract.
Upper tract.
Yeah.
Yes.
I'm aware. I'm aware.
Yeah.
Provided you have definite involvement of the upper tract.
Upper tract, right, sir, right.
There are cases reported about strictures, pyelonephritis, this, that, and all those things.
Right. I think there's another point that needs a little bit of clarification. That is post-operative mitomycin C. I think we have not discussed that point. So post-operative mitomycin.
I think we discussed that post-operative mitomycin has to be. We give in almost all the cases, at least, except if it is a very overtly invasive tumor. Otherwise, almost most of the cases even.
So my question is, what is your comment upon post-operative mitomycin C vis-a-vis an overnight or 24-hour bladder irrigation?
Exactly. We are having a study in our own department about comparison between post-operative mitomycin and normal saline irrigation, because there have been studies which show that they have almost equal results, normal saline irrigation and post-op mitomycin. So we are doing presently a study, and let's see the results also.
Yeah, because mitomycin C leads to a lot of irritation in the post-operative period. People complain of irritation and pain for 15-20 days after mitomycin C. It's a routine thing that we observe.
We have not been observing, at least.
We haven't seen so many irritating symptoms actually.
Regularly we are using mitomycin. With mitomycin, I don't think there are.
I mean, in my cases, it is more than 90%. I would say everybody complains of irritation for about 10 days or 15 days after TURBT, where I've given mitomycin C.
Okay.
I don't know. Even in my cases, after mitomycin, we haven't had much of a problem.
Okay.
I also agree that
never
I have not seen many cases of irritation after mycin.
You dilute with 10 milligram per 10 ml, so 40 milligram with 40 to 50 ml normal saline, and then keep it for just 1 hour. I don't think there should be.
That is exactly what we do, and I give it in the post-operative recovery only.
Once the urine
is clear, we give it.
With clear urine, absolutely clear urine. Then only we give it.
We give it, but I have noticed a lot of irritation in my patients. Maybe let's see if they have had infections.
Right. The one question about the random biopsies. Most of us are not doing random biopsies or posterior urethral biopsies. So, any comment on your in which cases you would do a random and posterior urethral biopsy? Which cases of bladder tumor?
So, with a positive cytology, definitely multifocal tumors. I mean, there is hardly any need. But recently, I had a patient with a frank CIS. He had low-grade tumors, and then there were reddish patches all over the bladder. So if one sees reddish patches and one has a positive cytology with a solitary tumor, then one should do random biopsies. It is never a harm to do random biopsies.
No, if there is some abnormal-looking mucosa, definitely you will take biopsy from that. I'm telling random means when the bladder mucosa appears normal, completely normal. But still, you would like to take a random biopsy and posterior urethral biopsy. Because one of the indication is if the urine cytology is positive and rest of the bladder is normal, then definitely you should go ahead with taking a random biopsy and posterior urethral biopsy. Any other indication you think?
Shivam, one situation which I do multi-quadrant biopsies when I am planning to do a neobladder. And when I'm doing a neobladder, I would definitely take some mucosal biopsies from the prostatic urethra and bladder neck area. So that is one situation I always do a mucosal biopsy before doing a neobladder.
There is one indication.
Yes,
very important.
Yes.
Shivam?
Yes, sir.
Localized bladder tumor, which has been confirmed that it is localized only in one place, and you want to carry out partial cystectomy. I did recently one robotic partial cystectomy. In those cases, when you go for a recystoscopy and rebiopsy, you must take random biopsy to rule out carcinoma situ before you decide partial cystectomy for the bladder tumor, particularly for TCC, because for TCC, partial cystectomy is just getting its seat now. It was not being practiced, but now there are a few cases, absolutely selected cases, where they could be resected, that where the partial cystectomy may be possible from the dome or near the dome and the lateral walls. Not the lateral walls, dome.
Right. So I think, yes, that is again one of the indications before doing a partial cystectomy. Yes. Any comment on the tumor in the bladder diverticulum? Dr. Nachiket is a very good resectionist. I have seen he does a very good TURP and TURBT, both of it. And once I saw him doing the large bladder tumor in the bladder diverticulum, he completely resected the whole tumor in the bladder diverticulum. And I think the results were also very good. If Nachiket comes in and gives his comment on that, I would request any comment from the faculty about the bladder tumor in the diverticulum. Can we go ahead with doing a resection in such patients and just wait and see? Or we should go ahead always with a partial cystectomy, with diverticulectomy or a radical cystectomy?
I think we have to do it on a case-to-case basis. If it's a very small one,
resecting a bladder tumor inside a diverticulum, there is a high chance of recurrence of local recurrences there. So I think, as Shivam suggested, doing a cystectomy is more prudent.
Yeah, definitely. Yes, Dr. Anshuman, you were giving some comments.
Yeah, so I was saying that if it's a very low volume tumor inside a bladder diverticulum, one can attempt its resection, because you see, it is not about the capability to resect, but many a times the bladder tumor will, the diverticulum will present to you with tumors in very, unreachable locations, where it will be just close to the bladder diverticular neck, or it will be in a crevice where you cannot access it properly. So all those are limiting factors. So if you feel from the look of it that it looks like a superficial tumor, it does not look like a high grade tumor, maybe you can take some biopsies and see the grade and all, and accordingly you can plan a surgery, that whether you would like to do a diverticulectomy or you would like to do a partial cystectomy or a total cystectomy, depending on case to case. We can resect tumors in the bladder diverticulum provided we have an approach to them. Many a times you will see that you cannot approach the diverticulum, you cannot have a look at it completely inside. So all these are limiting factors, and plus the thin wall, and sometimes you will see vascular pulsations in the diverticulum. You can see some major vessels behind the thin wall of the diverticulum. So you have to be very careful.
Right. If you cannot do it, definitely you would not be. But if you can do it, probably this is one of the options sometimes.
But one of the problem of doing a TURBT in a diverticulum is you cannot practically never reach the base, because the base does not exist. There is hardly any muscle underneath the tumor. So if you just go on resecting and reach up to the base, you are practically perforating the bladder. So maybe just for biopsy sake, resection of the tumor in a diverticulum is okay. But for definitive TURBT in a diverticular tumor, I think the guideline still suggests some sort of an open intervention in the form of a cystectomy or a partial cystectomy.
Exactly.
Yeah,
exactly.
these are the cases. These
Yes,
are the cases where partial cystectomy can be done whenever it is feasible. It may not be feasible for every diverticulum, but whenever possible, you must do after taking all those random biopsies, particularly biopsies from around the diverticulum, from the bladder, because that area of bladder has to go with the diverticulum.
Right. So I think we are almost at the end now. One more thing about, because many of the studies have showed that yes, a good and complete TURBT is probably the best thing to do. And the first time you do a complete TURBT, the results, the outcomes are the best. So I think there are many studies that have showed that we have to be very particular about completing a full resection and a good resection at the first time only. And many people have suggested even putting a checklist kind of thing before you stop the tumor resection or you just complete the whole operation. Then they have also suggested that every surgeon should put a bladder diagram when they are putting the operative notes, exactly showing where the tumors were and how much resection was done, everything, because that's very important. So how many of us do keep a checklist and make a bladder diagram? Any comment from the faculty?
No, we do it.
You do it, sir. I think that we should do it.
We
should inculcate this habit in our residents also. I think so. Thank you very much, Dr. Nachiket. Are you there?
Nachiket sir is not here.
Okay. So now I will again do this thing of the vote of thanks to all our invitees and faculty members who joined us, Dr. Kim Mamen, Dr. Anshuman Agarwal, and Dr. Bhatyal and Dr. A.L. Vyas to have joined us and made this discussion so interactive. Thank you very much, sir. Thanks.
My pleasure. Thank you so much
Shivam, for giving us this opportunity.
Thank you, sir. Thank you.